Welcome to this talk in Theatre D. My name is Mark Hindle. I'm from a company called Aura Healthcare. I'm the co-founder and COO of Aura Healthcare, and I'm going to talk to you about the innovation gap in NHS IT from my perspective, and some thoughts about how we can close it. Why am I qualified to be here to talk to you today? I was a director of a company called iSoft. I can tell you that because it doesn't exist anymore until about 2 years ago. And before that, I've worked at three of the other big vendors in what you traditionally call EPR, PaaS space. So I've got an opinion or two, and I'm here to share those today. So first thing first, what is the innovation gap? Well, for me, this is a life cycle view of healthcare IT. This is a slide that's well used in the industry. And I truly believe that traditional vendors operate in this space on the left, which is departmental systems have progressed to an end-to-end PaaS, and there's some integration between some of those systems. But in a healthcare delivery organisation, such as those that you work in, to get beyond that, you've got to either have a real good support at the senior team of the trust, you've got to have a deep pockets potentially, and you've got to have a willing vendor. So when I set off on this journey to establish something different to the big companies and establish Aura Healthcare, we looked at this innovation gap. So how do you get to the point of integrated end-to-end, anytime, anywhere access? How do you mobilize other people's data? How do you provide an environment in which you can actually give your end users what they want without relying on the big vendors to actually come up with a product and innovate? So we're going to explore that a little bit further. I'm going to talk to you from somebody that's worked at one of those vendors, give you my view, and then talk about some of the opportunities to do something differently. But this is what I would describe as the innovation gap. So to get the controversy out of the way, which I think is been heavily billed before the talk, did the national programme for IT stifle NHS IT innovation? Absolutely yes. I agree with what you're saying there, sir. The Computer Weekly journalist who wrote this in 2004 probably couldn't have predicted how accurate he in fact was. The LSPs knew absolutely nothing about healthcare and continue to know little compared to the domain expertise that exists in the healthcare delivery organisations themselves and the wider market. And standardised solutions was never going to work for the NHS. You can now probably begin to understand why a career in the national programme when iSoft was sold was not for me. But the market has changed. But the national programme for me was a unnecessary freight train that was going off the edge of a cliff because we were going forward with progress. Actually, what we ended up with was out-of-date technology, albeit to replace more out-of-date technology. And I think you could ask serious questions about value for money. I'm not going to go into those now today, but certainly the reason why we're here talking about this today is because the marketplace felt it couldn't continue in the face of the national programme. Meanwhile, the rest of the world happily moved on. So actually, everyone else is using social media in every aspect of their life. We have 60% of Generation Y members check their smartphones over breakfast. They do it before bed. 3 out of 4 people admit to that. Everyone uses smartphones in the bathroom, which won't be too pleasing for the infection control people amongst you. But healthcare failed to address this, failed to take us with them, with the rest of the world on this journey. So is it still relevant to talk about NHS IT and the traditional things we think make up a solution? This is a slide from EHI. You'll have seen this on the EHI website. I find it fascinating that everyone thinks a PaaS is core but not very important, which is the top line there. And various degrees, everything else more or less evens out. Clinical noting is an interesting one. So the first app I developed in Aura Healthcare was a clinical noting app. And everyone considers it as core. A few people consider it as important, but that's one example whereby the national programme just couldn't provide a solution or couldn't prioritise that thing. Look at how departmental systems fare in the middle of the same table. They're crucial. Again, they were largely outside of scope, or if they were in scope, you were going to get something that was potentially not quite what you had before, because the programme refused to acknowledge best of breed existed, refused to acknowledge that it was even a way forward. So little providers, small providers who were innovating in their own way with 1 or 2 customers, how do you survive in that marketplace? Well, thankfully the time is now. The time for me has changed. The marketplace this year is fresher than it ever has been, with new people, with new ideas, and finally we've got a way forward in terms of people acknowledging that joining these things together actually might work. So should we have done a connect all rather than replace all in the national programme? Who knows, and to be fair, we can't really do anything about it now. But let's explore a little bit further. I talked briefly about social media and the fact that the rest of the world moved on. We found in rolling out the clinical noting app that junior doctors would drive demand. We delivered hashtag clinical noting, and we couldn't believe the unprecedented take-up of it because of the generational change that's happened with people living with technology. So it's not okay to wait for vendors to provide you with a solution that's going to change your world. You have to harness the local innovation and provide a route to actually turn it into something that can be delivered. What else has changed? Well, excuse me, the healthcare itself has changed. People these days, so I talk to consultants quite often, and one of the things that most people do these days, if you're diagnosed and referred to a health system, is you Google your complaint, or you look on some of the Patients Know Best, or some of the other good industry sources of information that are accredited in some cases, to find out what's wrong with you. So information age healthcare is well and truly here. And actually organisations as well, the hierarchical, title-based way of looking at the world and sharing people with those who need to know is just gone. Everyone's talking about how we can share data and who should have access to that data. Paper records are still there, yeah, not disputing that. And yes, it is still relevant to have a conversation around what innovation there is and there isn't to take advantage of. Big EPR debate was something that eHealth Insider recently consulted on in the last 12 months. And all it kind of proved really was that it means something different to everybody that looks at the topic, and that's absolutely fine. So it's fine to have a strategy for me that's locally the right thing for you, and it's fine to have a strategy that fits in with 4 or 5 hospitals in your region and do something joined up. The fantastic work in Leeds is a great example of the Leeds Care Record. That's a great project. Is it still relevant? Well, let's acknowledge the things the national programme did well, the things we should be thankful for. The GP transfers, Bet Choose and Book, the spine services, EPS, Northern Ireland would love to have the electronic prescription service we have in England. It's one of the things that actually works. I'll leave the programmes for IT in the middle because we can make your own debate. But certainly, the legacy of the national programme is everyone's on the same page, I guess. For me, around sharing data. The patient is the centre. How do I build a strategy locally around that requirement? Now let's talk about this really topical point of and there's US vendors here today, US-based systems, but is a big one silver bullet system really going to revolutionise your health system? There's a few things to consider. The first is the numbers for the US speak for themselves. Spending more and approaching IT the way they do does not give them better outcomes and does not give them better care records. Yet we have this almost unhealthy obsession with the fact that they must be better because it's more expensive and it's best of breed. It's been around a long time. The only reason it's been around a long time is the same reason why you have nice mature systems for the car insurance industry here. It's because there's the private industry and people paying for this stuff means that the market is in a different place to the market here in the UK. But actually, when you look at the funding makeup, how could you possibly compare solutions that have been designed for the US with the UK? I'm not saying that they all won't work. I really like the work being done with Vista and bringing Vista to the NHS on an open source basis. That will have some application in the UK. There's also some good examples of products that have been taken to a good place and customised for the UK market, but it's definitely not a one-size-fits-all, and it's definitely not a silver bullet. I've talked a little bit about spending. Back in the NHS, actually we've got our own problems to solve, and we've got our own local issues. And all of this has gone on. Think of the things that have been introduced in the NHS whilst the national programme was preventing companies from taking things to market. As a start-up business, I feel qualified to say this, or as a year old today, and it's a tough market out there. Finding hospitals and organisations that feel able to step outside of the comfort zone of the national programme and to move on with a small company is difficult. But there's all of these challenges, all these problems to solve. You can see how simple would it be to implement, say, the dementia sequin, the single question to identify dementia. Have you been more forgetful in your everyday life, etc., etc., and just get a yes or no answer? there are trusts around here, and I don't know if any are in the room, there are trusts that are producing bits of paper, sending them to wards via the porters to be able to have this thing ticked and sent back to the data collection room. And that's just one sequin. But the paper gets ticked and sent back because it's a sequin and because it's linked to results and linked to funding. Think of our own problems. SMS reminders, another cracking example, and there's companies here that can do that today. Really low cost, could make a good difference where they're there. Simple stuff, can you text back? Technically, yes, you can. Text back, that's absolutely easy to do, right? You can everyone here has probably texted, even sat here listening to me today. But actually, it's not really prevalent in the NHS still. Simple things. So what I'm trying to say is there's a definite need for companies with solutions or the right way of thinking or the right technology to talk to healthcare delivery organisations. So what's the potential? Well, actually, you might have seen this infographic. It's one of my favourites. The potential is huge. Where it's been surveyed, everybody says, yes, I'd quite like to do that. Finally, NHS England are on the same page as the rest of us and are saying some good things around how healthcare can benefit from using the technology. If you look at the digital challenge they set, the digital material and web videos they put on their website, 70% of us already search for health information online, and 80% therefore would obviously like to see their own record online. Well, why wouldn't you? That seems a nonsensical thing to do. Online GP booking service, well, it'd be great if it was just as convenient as a hotel and not quite as cumbersome as choosing, but can be in some cases. And this massive potential around asking doctors questions and being able to respond. There's definitely potential there. But then, if you look at what we should be able to do in the future, this always makes me smile because technology out there is something that the rest of the world has harnessed in various cases. And I'm not saying that everyone other than healthcare is doing this fantastically, but there's definite precedent whereby we've relied for too long now on the vendor sitting in the ivory tower designing the product and dictating to us what the functions will be. That's just wrong. Simple things. We should be searching reviews of best treatments. Friends and family test is a step forward in the right direction. What could we do if we had the right technology to solve that problem? Narrowcasting, that's a good idea in terms of non-urgent messaging. How can you have an always-on stream of my preferred delivery organisation? I have a preferred local hospital or two. You might have if you have different healthcare needs. How do you stay in touch with that organisation? How do you signpost yourself to those services in a way that's some way personalised? Are we going to tackle the whole issue of personalisation? Are we going to offer that step forward in terms of, actually, this might be appropriate for you, Mr. Hindle. These things, based on what we know about you, is appropriate. And it's not as if the UK is not an innovative leader. I'm sorry about the size of that, you can't see it. But effectively, the darker the colour on the maps is the hotspots of innovation around the UK and where the different firms are and where the different technology is happening. We're quite good at innovation. The problem we've had in health is just being able to bring together the solution providers and the people with a problem, the delivery organisations, and then providing a way for them to do business. So I've seen a couple of different ones. I'll go back to the Northern Ireland example. They have a technology partner agreement whereby they buy things through a preferred partner, and trusts can invite people into this conversation. So instead of a framework where someone gets exclusivity, the trusts can co-opt people onto the framework and things can get bought that way. It works. Let's continue the controversial theme. Let's talk about vested and commercial interests in the market. Because this is one of the core drivers of why innovation's been hard to come by. So we might as well tackle it head on. Honest view, and in a nutshell, there's few commercial opportunities for traditional vendors to do anything that wasn't really going to get funded by the national programme between 2004 and 2012, because why would they? But, as a business, why would you possibly consider doing anything that you wasn't going to get funded for? And it costs money. Developers are not that cheap to hire, and having a plan and a strategy and a product that you can build costs money. Definitely a sense of awakening. I thought that last year at Live, we're emerging out of what was the national programme. But then controversially as well, and I've seen some of these in my time, did large system maintenance revenue contracts also stifle the NHS? Because what that means is Mr. SME going along to an organisation and saying, I've got this great idea, I can really help you with this I've seen you've developed this app, I can help you plug it into your existing infrastructure and perhaps send results back here or right back to this other system. All that technology is out there today. But actually, you've already committed 90% of your funding to your existing vendors. So Are the days still here when IT director is going to sign an invoice to a large-scale PaaS vendor for a £300,000 to £600,000 annual maintenance contract to use Microsoft SQL 2000 and a proprietary data structure? When everybody here, the Handy App Village, people are building apps and walking away with them today. The Skunk Works, people are being able to create things on open source technology. And yet we still are presented with invoices to write for ridiculous systems. Now, I say ridiculous with a bit of, it's probably a bit too far. I'm all for buying IP, right? If people have got good IP, people come up with a good idea, of course they should be able to sell it in the marketplace. But it has a fair value that until now really hasn't filtered down to the invoices landing for payment on the IT director's desk, in my opinion. So if you have no catalyst for development velocity in the market, and velocity being speed and some direction, and thankfully some direction is now coming from the centre, but actually if we would have asked the trusts all along, perhaps it would have been there, then it's no surprise that we are where we are. Personal view, proprietary data models from any vendor are not acceptable in any way, shape or form. 2 weeks ago I was with Dr. Shannon in Leeds, who was telling me about the Open EHR project based there they've got for the Leeds care record. Fantastic. They can invite multiple vendors in. As long as the data gets aggregated up to the Open EHR data model, then they can join the party. It's a contained lab for you to innovate in, but the data model is not proprietary owned by one company. A massive bugbear of mine is also interfacing. Do we want to pay X £1,000 for someone to give you an HL7 interface that was already there and you're just switching on? I mean, we have to challenge the vendors in the marketplace to ensure that they know that we know, if that makes sense. They know that we know that the technology is now out there and they they shouldn't be able to hold us to ransom in some cases. I also think there's more that the NHS England can do in interoperability, in defining and formally promoting the mandatory standard in joining together the systems, rather than us just having to try and do it ourselves or rely on local projects. The good work of the MIG, the MIGs that have been going on where people have been sharing data in around primary care is a good idea, but how can we widen that? So you'd expect this from somebody coming out of corporate world into an SME land, but you need to have a shot at the prize to disrupt the market, and thankfully the government is giving some thought to how that might happen. The SBRI initiative, the NHS Tech Fund in some cases, although a lot of that's for pre-existing projects, but local initiatives, local ideas of how do we take forward innovation in our organisation, who's the right development partner. And that's where what we've done is actually I think I know a thing or two, but I'm no expert in, for example, the depths of clinical noting and national early warning score integration. But our customers are, generally. So what we would do is work with organisations to make sure that the domain experts get the solution that works for them. And that's where we've built our referenceability. Used this slide before. What does best of breed look like? The answer is, I don't know. You might have your own bag of bits, and this is one particular bag of bits. I guess the point I'm trying to make with this slide is, it's okay to have a different perspective on what best of breed looks like for you. We attended a big EPR debate 2 weeks ago in Leeds, and one of the things that came up there is everybody had their own definition of EPR, but as long as the patient record was there, was cohesive and was integrated, actually does it matter which bit of functional component, whether you've got who's e-prescribing you've got and who's outpatient scheduling and who's A&E system. The fundamental choice in best of breed is allowing your own organisation to decide which bits work and helping them interoperate those things. And that's not too hard to do. This is an unbranded one that you could quite easily adopt internally. Decide which apps are in the middle, the things that you really need to do straight away. Introduce over time based on required, or what you've already got. On the left there, your additional components. Let people have access to it. Build an integration platform. Make your MPI accessible to the systems. And then this is where I want to focus on what really we need to do to adopt innovation. So most hospitals have a continuous improvement cycle. You have this ability to be able to take people out, and less so in these austere times, to look at new ways to solve old problems. Well, really that needs a short circuit with new ways of thinking. Sometimes, lots of trusts we would talk to now have got somebody inside the organisation who's thinking about doing things differently, thinking about how we could do this if we just had somebody who would tell us honestly about the technology. And that's the kind of interrupt I think that needs to happen in the marketplace, and where we're trying to disruptively innovate, if you like, to really come up with new solutions. I don't know all of the answers or all of the apps or all the widgets that you guys might need sat there today, but I know that I'd love to have the conversation, and so would lots of other of the small companies sat here who've got half an idea. And how do you harness it? Well, let's look at one example. Let's say that you invested in one thing, an app development gateway in the middle there. You could take all the things in the handy app village that have been built here, and you could, or even write your own and mobilize other people's products with these kind of type of apps. And you publish that app development gateway, and people can then innovate against a sounding board. It's just like the Leeds model. It's just the same thing. Actually, they're inviting people in. If you've got a great idea, come in, try it out against our open EHR model. If we like the clinical context and the IP and the use case, actually, why would we not adopt it? And look at where else that's been done. Let's take Facebook, the world's largest social networking site, we all know. The bit we actually want is the bit in the middle. We want to realise the benefits in the middle. We want people to connect in an online, let's say any town NHS trust wants an online community portal for all of its people. We want research, we want social context, we want people to be able to talk to each other, user groups of conditions, personalised experiences that we can facilitate. Then we get the follow-on effects, which are the networks talking to each other and different apps spinning off from that defined need. But what the NHS can't afford is the bit at the bottom. We can't afford the capital to set this up, we can't afford the experts to do it, and we can't afford the recurring revenue for sure as that economy develops. But all you have to do really is publish that ability for apps to soundboard against your data in a way that actually is of interest to them, and have an operating framework with those people that they can then take forward their own commercial interests. It's been done already. In the Healthy Share is a good example. This is a very simple one, just identifying people around you and it introduces you to people that might have the same condition. It's a Facebook plugin. But there's growing numbers of research now that suggest that patients are happier when they feel things are personalised to them, but yet we're still not currently able to offer that off the shelf. So, to sum up, I think that the first thing to do is to talk to organisations who provide solutions. There are a few out there and it's hard to find the right one, okay? And I acknowledge that, but we have to make an effort. And certainly, point 3, an ecosystem, has been a way that I've seen, and the academic health science networks that are emerging, that this might happen. It's a good place to take your problem and have a mini competition outside of all formal procurement to figure out if anyone's got half an idea you might be interested in. Would your clinicians actually use that app? Could you plug it into your existing estate? What about writing back to that system over there? And it's okay to think about surround, supplement, augment, replace, reimagine, redeploy. All these things would be conversation points when I go in and talk to a customer about a problem. I've already told you my view on connecting all versus replacing all, sharing your own data, be interoperable, and then consider, actually when a vendor comes in and says, I'm going to give you this, say an e-system you've asked me to give you, it's actually what I want you to do is, here's our MPI, I don't want you to hold your own actually, because I've already got 17, I'd like you to just use this core one that's my golden copy, and I'd like you to integrate to and from. And I'm not interested in sending you updates every time Joe Blogs changes their address and we get 75 different update systems we have to update. How about we just make the change and start saying, actually, just use this record, just read this record, and that's all you need to do. There's definitely new solutions to all problems. Web 2.0 gave us new technology. I went on a course the other week to code in a day. There's a not-for-profit in London and in New York called Decoded, and I would definitely, it's a plug, but only because it was fantastic for what it cost. And you walk away with an understanding of code and concept, and you walk away with an app. My app actually told me the proximity from my own GP, and then when I got there, it offered me a set of menu options, and I coded it in less than 8 hours, including all the specs and lots of breaks and so on. So, that technology, I wouldn't be afraid of it, and not all of the companies out there are willing to embrace or offer it to you, because it's still okay for me to say, actually, oh, you're thinking about mobile, well, don't think about tool sets or building it yourself, perhaps, or don't think about using 3 or 4 different companies to innovate different directions. Instead, you take my off-the-shelf, premium, proprietary mobile version, and it will rock your world. Not always. There are some examples of very good technology here, but what can you really configure? Is it really worth the value for money? I definitely wouldn't be constrained by the same old suppliers. You can see them here. The EHI has been a fantastic supporter for a small business and a fantastic supporter for new entrants. I've already mentioned the good work with the innovative healthcare app village and so on that's been done here. And having those types of conversations with those types of companies will help you find the right tool for the job. It's not always about an app, definitely not always about an app, and it's definitely not always about writing a bit of software. Lots of stuff can be written in the browser these days. Lots of stuff can, you might need something that already exists in open source world and just 3 or 4 components bringing together. Other thoughts? So harness that app army. NHS England's doing well to prescribe what but not how. Definitely think about sharing your problems with those people around you, because just pay once. That's, talk to suppliers you would consider. The fact you could split the cost with 3 other trusts nearby. Think about personalisation. The US Blue Button scheme is fascinating. I know you'll have heard about it before, but if you haven't, Google it. Development partners are a good way out. And SMEs are not always a risk, but they might not always have 3 years accounts. And that's the other final point, is to deal with some of these companies, you need a different route to market. Because I'm bored of getting notifications from tender responses or from conversations with customers that we can't get through the financial checks to get on the system because we've only been going for 12 months, 18 months at a push. Actually, that's a challenge you have to help us get through, as the demand has to come from the market. So, final thing from me, this was Edwin Poots, Minister of Health in Northern Ireland, a little speech from him. Basically encouraging the health system in Northern Ireland to do things differently and acknowledging that everything won't always work, but he would value those that try. But we need to be quicker at recognising better practice and implementing it more broadly, I think was a key thing for me. And with that, I'll take any questions.